Good evening and welcome to another Monday evening show of Fresh Natural Live. And it's Monday evening, and we have a great show for tonight. I've been watching a little bit of football lately and recently noticed some news about a young quarterback, the starting quarterback of the Miami Dolphins, Tua Tagovailoa. And I'm going to have time to practice that last name tonight, so I'll get it right before too long. But nevertheless, he suffered a number of tackles that were pretty critical and had a head injury. And so the issue of concussion, reached the forefront of the NFL. And we're going to talk about traumatic head injury. And I brought a friend and colleague on who's an expert in the area of neurology in general and deals with patients with this type of injury. So she's going to enlighten us about this and talk about the broader scope of traumatic brain injury as it affects all of us. So sit back and get your pen and pencil ready. I have mine ready because I think you're going to learn a lot tonight as we typically do. So stay tuned. All right, welcome back. So, as I said in the outset, we're going to talk about traumatic brain injury. A couple of incidents occurred in the NFL. And of course, you remember last week we talked about an NFL player that had some medical issues. So, you say, well, Montgomery, you've been watching a lot of football lately. Well, maybe not a lot, but I saw a few critical games. And, but some very important medical issues have come to the forefront. And so, we're going to address this. I'm going to bring on my usual colleagues, Dr. Pamela Brewer Atkins. Hello, good afternoon. How are you doing?
Hi, doing well. Glad to be back. I've been traveling a little bit and checking on family, but it's good to be here with everyone.
You're back settled in. And then your
Yes.
partner in crime, Dr. Ford Atkins, sir. How are you this evening, rather?
I am doing great. Just happy to be here.
So looking relaxed as usual. So as I said, we're going to talk about this issue of traumatic brain injury. And a special guest tonight is a colleague and friend, Dr. Rita Achari. Dr. Achari wasn't born in Texas, but she got here as soon as she could, according to her website, and thanked her lucky stars. She received a BA in biochemistry from Rice University, so we have that in common, and earned a Bachelor of Fine Arts in History and focused on filmmaking, which is interesting. And so I just got into filmmaking. So we'll have to talk about filmmaking later on, maybe after the show. Her decision to choose medical school over film school was based on which profession allowed her to help people the most. And so she's been in private practice since 1997. She attended the UT McGovern Medical School, received a doctorate of medicine in 1992, did her internship in McGovern Medical School in internal medicine, followed by a residency in neurology. She completed her fellowship in epilepsy and clinical neurophysiology at the same institution. She's certified by the American Board of Psychiatry and Neurology and maintains certification via periodic requalifications. As I said, she's been in private practice since 1997. She practices general neurology and is skilled in diagnosis and management of a wide range of neurological disorders. She integrates clinical findings with neuroimaging, neurophysiology, and other studies to form an accurate diagnosis and appropriate treatment plan. Over the years, Dr. Char has developed the specialty of nutritional neurology, which uses scientifically validated laboratory testing to assess cellular micronutrient content and needs. Her practice is a scientific, evidence-based, holistic approach to the diagnosis of treatment of patients with neurological issues. She's active in the professional societies and is board member of the Texas Neurological Society, where she also serves on the education committee. She is a board advisor for the American Society of Neuroimaging. She is a member of the Independent Practice Committee of the Harris County Medical Society and chair of the Women Physicians Section. She's a member of multiple professional organizations, including the American Academy of Neurology, American Society of Neuroimaging, American Epilepsy Society, and the Functional Neurological Disorders Society. She's a member of the Texas Medical Association and American Medical Association. She is clinical associate professor in the Department of Physical Medicine and Rehab at Montgomery Medical School. She's active in mentoring future physicians and neurologists. And I can personally say, despite doing all of those things, she has time to go to the farmers markets on Saturday mornings because I've seen her there personally. Without further ado, welcome to the show, Dr. Achari.
Thank you. Thank you so much for having me. I'm glad we reconnected at that farmer's market.
Absolutely. And so, interestingly enough, we all have a connection. I think the Atkins actually are located in Costa Rica, and we were supposed to do a wellness conference in Costa Rica that was canceled. So I think there was a quasi Costa Rica connection here. But without further ado, I want to get into this topic of concussion, quote unquote. And we were talking behind stage, and you enlightened me in a number of ways, even before coming on. And one thing you stated that really caused my eyebrows to raise is that the whole concept of definition with concussion is a problem. There's the mechanism. Mechanistically, maybe we need to talk about traumatic brain injury and the like. And so I thought that was quite fascinating. And of course, I shared some videos with you that I've been looking at, and about certain experts saying, well, you have this injury and this mechanism and so on and so forth. And it was interesting that you shared with me that our diagnostic capabilities are not where they probably should be in terms of diagnosing this entity, and our definitions are probably not where they should be in terms of truly understanding what we're dealing with in the clinical setting. Can you just enlighten us about those concepts that we talked about before we get to the featured show at hand with this unfortunate football player?
Sure. As you and I were talking about, we don't have a unified common language. I do want to also state, though, because we were talking about the Oilers recently, that I am a football fan. I love football. And for me, I've sort of stopped watching because as you understand these hits and it becomes hard for me to watch. So I've stopped watching in my tiny little bit of protest there. But it is not that I don't have a love for this sport, right? So I want to start by saying, hey, I'm a fan. When we talk about concussion, we use the term concussion. No two concussions are the same, and we don't actually have a very good idea when I'm talking about concussion, someone else is talking about concussion, neuropsychologists is talking about concussion. So we have not even gotten to the point in medicine where we have a clear and unified language. Should we be calling it a closed head injury? Because some people will have a head injury, you can hit your head, and not necessarily have any neurologic deficits following. You go on, you're totally fine. You may have an injury to the head, you may hit your head and have a headache, and then you're fine. You may hit your head and feel foggy and have a headache and feel dizzy and nauseated. All those things can happen with the same impact, but to different brains. So do we call this, a closed head injury? Do we call this a traumatic brain injury with neurologic sequelae? I mean, neurologic problems afterwards? We need to, first of all, come up with a unified vocabulary and unified language, right? We share information better when we're able to call something the same thing and we know what we're talking about.
Yeah. It's interesting that I'm sorry, but and I'm glad you pointed that out because, when I looked at a lot of the different discussions, if you will, online, and especially there's one neurologist who talked about we have a management problem, and if once you have a concussion, it takes 4 weeks to fully recover, and so on and so forth. And I said, wow, that's amazing, because I can imagine, players are getting concussed on a regular basis, and to think that everybody needs 4 weeks. And then I started thinking about boxers and boxers who are getting punched to the head all the time. And you go one ring and you're staggering, and then you go the next round and you're back to it. I'm saying, well, if he had a concussion on round one, and he's back on round two, gets another, I can only imagine that these injuries should be very serious. And so when you say that, hey, it's different for different people, that helps me understand, all of these different scenarios a little bit better. Because here's one person had an injury 1 week, 4 days later, he has another injury and it's very severe. And I've seen other players have concussions back to back in a similar fashion. It's not as severe. So that's interesting. I'm glad you pointed out that level of lack of understanding and difference from brain to brain, because that helps me understand what we're seeing in real life.
Yeah, and you brought up something where we do have a lot of information, which is boxing, right? Boxing, for hundreds of years, we know that repeated trauma to the head as you get in boxing results over time in a type of dementia. So it develops into Parkinson's dementia or disease, which Muhammad Ali developed. And then there was another term for recurrent head injury from boxing called dementia pugilistica, right? So people would lose their memories, but it's constant. It's just blow after blow after blow in training. And so that's one thing. When we talk about other kinds of, I'm going to use the term head injury for the purpose of our discussion. When you talk about other kinds of head injury, the mechanisms may be similar, but the brains are different. And so that it makes a big difference in how we respond. Well, I'll just, I may have lost the idea that different people are responding in different ways. With setting up a definition, that's the first thing that we have to do. But the other thing, when we look at these injuries, what becomes clear is we need to do a better job in identifying, right? We've got to look at the signs and symptoms, and clinically at the sideline be able to know in sports or anywhere else that someone has suffered neurologic injury after a head injury, right? Not all head injury is neurologic injury necessarily. And I think that was a big thing that was sort of missed here, because, I think you're going to show us some video, but we have to understand when we look at somebody and the immediate after effects of a blow to the head, that somebody has had neurologic issues, especially when it's immediate like this.
Yes.
And then we have to be able to, in sport, recognize, advocate for the player, get them safe medically, allow them to recover, restore, and then return, right? We want safe return to the profession for those who have spent a lot of time and effort and heartache, heartbreak, and sacrifice for these professions.
So, and those are great points. And what I'm going to do, I'm going to show you some video. I'm not going to ask you, as I said before, I'm not going to ask you to play Monday morning quarterback. I'm just going to ask you to play Monday evening neurologist. And so I'm going to show you the first injury. Well, I'm not going to show you the first injury to Tua right away. I'm going to show you an injury to another player, Naeem Hines, who's tackled. And then after I show you Naeem Hines, I'm going to show you Tua Tagovailoa's injury. And I'll show those back to back, and we can discuss those before we go into Tua's second injury. So here's the first one, the first player, Naeem Hines. And let's take a look at this.
7. Ryan hangs in the pocket, throws, and has to move up toward the line of scrimmage. The catch is made, but they don't get a first down. Hines about 1.5 yards short, and once again, Indianapolis cannot score off its first drive. They haven't scored a single point over first drive this season. And meanwhile, of all things.
Oh, boy.
Well, we've seen stumbling, and you know what I'm talking about. Hines needs some help to just remain upright.
Yeah, he got hit after this catch, just trying to make something happen. I think he got hit from behind. Right there was the contact that knocked him down, and you could see the reaction that he had after that hit.
Sure did, right? And there
boy.
it is. Oh, man.
Just hate to see it.
Don't need any more of this. So they will walk him to the bench and check him out thoroughly. And it's 4th down and 2, and once again it's a 3-and-out on Indy's first drive, and they'll punt 1 minute and 3 seconds into the game. So you're going to see a lot of Philip Lindsay now, maybe even more than you thought, and Deion Jackson is the other running back. So 7.
So here's the other one. I'm going to show these back to back, and we can discuss them before we get to Tua's second. So here's Tua's first injury.
Are in trouble, 0-2. Tua Tagovailoa throwing off his back foot with the rush in his face there. Jalen Waddle makes the catch. Penalty flag comes in, and Tua Tagovailoa was roughed at the end of the release. The pass rusher came on top of him there, and Tagovailoa suffered some type of an injury on this play. We have Teddy Bridgewater in the game right now. Tagovailoa, oh boy, getting up. Oh, my goodness, that's an awful, awful sight to see. They will take him to the sideline immediately. Oof. Okay, Tagovailoa, in fact, going up the tunnel into the locker room, and Teddy Bridgewater has come into the game for the time.
So there we have those 2 injuries, and both of them are staggering after they get up from the ground. So let me just ask you to just, based on your observation, let's say we're going to put you're the neurological consultant on both of these situations. What are you seeing here from a neurological standpoint? What questions are you raising? And what's going to be your approach? You can do them separately, or you can group those 2, etc.
So I want to sort of, point out in both of these situations, when the players get up, right, they are staggering. They're not actually walking clearly forward. They're off balance. And the interesting thing is both of them lose their footing. The legs give way, right? If this were to be a back injury, right, somebody got hurt in the back, people will limp. They don't lose strength in their legs, right? We've all had back injuries. Mm-hmm. We don't all of a sudden lose strength to both of our legs, and we don't just, kind of stagger. If you look at the mechanism, both of the players, Tua, of course, got hit, and he had a big sort of neck whiplash injury along with it. And Mr. Hines, he fell sideways, and there was almost a torque to the neck. So so I think that there is, and I'm going to use this term, neurologic injury, right? Is it head? Is it only brain? Is it brain and then the fibers going down through the spinal cord, where there now you've got this big electrical volley from an injury going down to the spinal cord, and now the fibers going into the legs, right? The nerves through the spinal cord, going into the legs are not working. So when you see somebody stagger, legs give way, weakness, right? Weakness is a neurologic manifestation. When we're talking about orthopedics, you can't move something because of a joint or muscle, but that staggering, that losing the ability to keep oneself up, both legs, by the way, and both those players.
Yep.
And the first one you showed us, the one that happened more recently, as he tries to walk, one leg crosses over, right? His coordination is no longer there. He is no longer in control. This is a finely trained, physically able athlete who can no longer control his motor actions. That is a neurologic injury. And I think that we all saw it.
Yes.
I think that's the thing. It happened live. We all looked at it and went, ooh, something's not quite right here, because we're used to players. We've seen players fall, injure their backs. They hobble, they limp.
Yeah. That's the coordination. It's interesting that you mentioned brain versus brainstem or cords going down the neck. So it seems as though we think of just the cerebral cortex and all that, but you talk about torquing of the neck or whiplash. So also in the differential is injury to the neck, the nerve fibers going down the neck. Would you consider the cerebellum, the fibers coming from the cerebellum or the brain stem or?
Yes, and so the brain stem, the cerebellum, all of those fibers come down. There are spinocerebellar tracts, right? So all of those are coming down, and these are all, the nervous system is all connected, right? By fibers, by wiring. So it's all one. And we try to move, here's brainstem, here's spinal cord, here's nerve. But really, when that central nervous system and peripheral nervous system, brain, spinal cord, and you've included cerebellum, the coordination center, they're all being, the injury to all of that is being manifest in how these players, when they get up, what they're showing you through their activity. They have clinical evidence, right? We're looking as physicians, we look at signs and symptoms, and my goodness, we've got it right there. It was plain for the world and anyone who's watching that game to see.
Wow. I'm going to show you the second injury of Tua, which really got a lot of news. And there was some experts. There was one particular person who's a PhD, and I should have flashed his picture up, who tweeted out before this game saying that Tua should not play. He had a concussion in a recent game, and if he plays and gets injured, it's going to set back, football, several years. And he clearly said he shouldn't play. So let me show this, and let's take a look, and we'll get your comment.
His ability to make adjustments at halftime.
Tua rolling left with the grain, and down he goes. Slung down on his own 48-yard line. Josh Tupu. And well, we saw last week, and he went down, he got up, was wobbly. The training staff comes out. And, of course, the last thing the Dolphins wanted to see. I mean, last week it looked for all the world. Everybody thought head injury, concussion, passed the protocol, came back second half, led him to a victory.
And Al Tupo slams him to the ground. I mean, you're thinking about the back, the ankle, but he gets thrown to the ground.
Again, wrenching that back, which was the issue last week.
Yep.
So they work on him. We'll step away for a moment. Not going to speculate, but Tagovailoa is still down as they work on him, and we'll show you in a moment the way his fingers were stretching out at the end of that play. Comes down on his elbow, comes down on his back, comes down on the back of his head. With serious force, he goes down.
Right, and right as he goes down, you could see both his hands. You just get right away, you get concerned. They're bringing a stretcher out right now. And he was brought down. I mean, a big man bringing 340 pounds, bringing him down with a lot of force right onto his back and on the back of his helmet. Off of the week that he had last week. I mean, he's just being a gamer playing tonight, trying to be there for his team. Could see the concern of the rest of his teammates.
They'll take him back, and Teddy Bridgewater will come in when play resumes. Talking to our sports medicine analyst, longtime trainer for the Jacksonville Jaguars, before that the Giants. And Mike Ryan tells us when he sees that, and he's watching this as you are as well, it's a neurological response to head trauma. So they're stabilizing him right now. Head hits the turf. Elbow hit first, then the head. And in a heartbeat, it just turns around just like that.
Again, worth mentioning it. Very similar sack last week, or push from Milano, the Buffalo line, when he hit his head on the game last week. See these players all huddled around him right now. Jalen Waddle, 17, who we saw earlier, he, of course, went to school with him in Alabama, has known him for a long time. Let's see how concerned he is.
So Tua, and the Tua chant going up from the Bengal crowd. Popular around the country, such a great, college career, obviously.
Just one of the more likable personalities you'll ever come across.
Yep. And they'll take him back initially to the locker room. There was the coach, Mike McDaniel, with the send-off, and we'll get, as soon as we can, obviously, the official word as we hear it.
Yeah, you can hear the whole stadium yelling, Tua, Tua.
Stabilizing him, keeping the helmet on as they wheel him back. And so Teddy Bridgewater, no stranger to the NFL, as a starter.
So anyway, I played that a little long because I looked at that several times, and I'm going to get your comments on it. But I noticed, the posturing of his arms, of course, the fingers, they showed a lot. What I could not determine, one, it seems like he was completely unconscious, but there were so many people around him, it's hard to tell. But the other thing, too, is that it seems like his arms stayed in that posturing position the whole time. And if he was on the stretcher, it seems like, it's hard to tell, and I'm going to get your comments, obviously, but his arms were down some, but it seems like the straps were holding him down. It wasn't like I don't know if he came out of that posturing position. What's your take on it? What were you able to see? What were your observations of?
If you look at how he goes down, I mean, this is a really unfortunate injury. He does something. He's on his side, and he goes into a position like this first, and then he kind of stretches, and the arms kind of go like this, right? And there's a little bit. I mean, he's got his fingers in a sort of dystonic, so abnormal posturing in those fingers. And he's there for a long time, and he is unconscious. I mean, clearly unconscious. I don't know at what point, when they got him back on the stretcher, I don't know at what point if he regained consciousness when they took him out. I mean, I have no idea.
Yeah, I can't tell either. It seemed like he was still unconscious to me.
Yeah.
I mean, oftentimes players give a thumbs up sign or something,
Yeah, that was a major injury. So what I wonder, because his head got hit, and of course, I think he had a concussion 4 days previous. Yeah. So when he gets hit this time, there can be several things happening. One, that a massive head injury with a large electrical volley that, again, goes down through the nervous system, and he's unconscious. The other part about this, and I'm an epilepsy person, so I look at this and I go, wow, he's had a traumatic brain injury, right? We're going to talk about these as head injuries. He's now had a traumatic brain injury, and he may be having a tonic, so maintaining of posture, not shaking, not the clonic part. He may be having a tonic seizure, right? So that's a possibility as well. These things are so opaque. We don't really know what happens to athletes and, what happens afterwards. That, the only thing this poor man, poor Tua, is out cold. Is it just massive injury and nothing else? Is it massive injury with a post-traumatic seizure happening right there, right? And if you get hit, you have a closed head injury and you have a seizure, the closer it is to the injury, the better your outcome, right? So that's good news. That's good news. But having an injury, having two injuries back to back, with the second one now, you're seeing it's a more profound result than the last one. So that's cumulative injury. That's not ideal.
Yeah, and that's some of the comments that were made. The thing is this: so he is hospitalized. I think he's discharged after a day or two. I don't remember the details of that. Or maybe no, within the same day, actually. He's able to fly back with the team. So he's discharged. So he recovers, I guess, within 24 hours, flies back with the team. And they said he's laughing and talking, apparently making a full clinical recovery on the way back. What's your assessment there? So we're going to put you in the, now granted, you don't have all the data, imaging, or anything else, but apparently there weren't bleeds or whatever, anything required him to stay in the hospital. So he's discharged, full clinical recovery. What say you?
Well, someone with a closed head injury, a head injury, without significant bleeding, without significant swelling to the brain, does not have to remain in the hospital, right? They can be evaluated, they feel better, and if they've got their faculties, et cetera, they can go back. Now, he's in a special situation. He has team doctors around him and trainers and everybody else. The rest of us may have stayed in the hospital a little longer if we weren't completely with it. Now, the thing about head injuries and brain injuries, because now we're going from head injury into brain injury. We now know these are two brain injuries. You can look perfectly normal on the outside, but your brain is not normal on the inside. So the things that we don't have, he may be laughing and joking and all of the other things that we're told, but what we talk about neuropsychological testing. So what's happening with his memory? What's happening with his mood? What's happening? Is he dizzy? What's happening with his sleep? Because these are all the things that are disturbed in a traumatic brain injury with, neurologic sequelae, which is neurologic problems. These are all the things that we don't get to see. Someone can move, they can do everything just fine, but their brain is not fully recovered. And sometimes within the first 24 hours, 48 hours, people seem normal, but then when they get back to normal life, there are things that are not quite right. So the irritability may not be seen for a week or 2 or 3 or 4. The dizziness, the balance issues, memory, it can be very subtle. But it is unlikely that someone with 2 head injuries and the second one resulting in loss of consciousness, we don't know how long, with posturing, which we don't know whether it's just, brain swelling, electrical activity, or a seizure. I'm making a lot of guesses here.
Wow.
These are all the things it could be, but his brain has been injured. So, if he had a fractured arm or a clavicle, he'd be taken out and he'd let that bone heal. The only thing with a brain injury is you can't see it. It's not obvious, but the brain still needs to heal. And I think that it would the statements on before the Thursday game that Tua probably should not be allowed to play, that was quite prophetic. But I think that perhaps people who are in the know, there was no mention of a head injury or concussion after the Sunday night game.
Wow. Wow. You touched on some great points, and I think a lot of these can be extrapolated to the broader clinical spectrum. I know Dr. Pam Atkins, Dr. Floyd Atkins have dealt with patients who've dealt with falls. We have patients that with falls a lot. And I often don't think of patients with falls to ask questions about, traumatic brain injuries. And so that's really something that I think, as now that we've examined these, what I would consider extreme cases, maybe we're probably dealing with extreme cases also in our clinical practice more so than we know. But clearly, these are extreme cases where you see, before everyone's eyes, someone with these neurological symptoms. And I think, as you pointed out, these are young, healthy, physically fit men who have overt neurological symptoms. And so that really speaks to the, I think, severity of it, given the fact that they are in such good shape. Their brain injury must be pretty significant. I think someone who's older with previous strokes, the water's already muddy, but with these guys, the waters are not so muddy. So I think it's quite interesting. What I want to do is I want to take a quick break, and on the other side, come back, and I want to touch base on some of these broad implications that you mentioned in terms of, okay, someone's had a fall, someone's had a potential brain injury. So now I want you to come into my office or Dr. Atkins' office, and so we got a patient says, well, grandma fell and hit her head. They went to the emergency room, everything's okay. Now, what do we do? How do we think of it? What assessments do we make on the clinical side? So before we go to a break, I want you all guys to hit the thumbs up button, share, and if you haven't had the opportunity to subscribe to this channel and hit the notification button so you get notification of other information. But we'll be right back after a few seconds. Okay, we are back with Dr. Achari and my colleagues, Dr. Ford and Pamela Atkins, and we're talking about closed head injury or brain injury. We just, on the first half of the show, examined a couple of players in the NFL who underwent some pretty vicious tackles, and in both cases had, a neck injury, or whiplash, or torquing of the neck, or in one case, the head bang against the turf. I'm glad Dr. Achari pointed out the torquing and whiplash component, because one thing that baffled me a little bit is that I said, "Wow, their heads did not hit very hard," and I always thought of closed head injury or concussion being related to the banging of the head. But in both cases, it was pretty obvious that they had a torquing or whiplashing of the neck. And she pointed out very astutely that, the spinal cord could be stunned. And so that connection to the lower part can explain these neurological symptoms that they had on the field. But Dr. Chari, you touched base on some great points in terms of follow-up evaluation. And this clearly, comes into our turf. I frequently evaluate patients due to syncopal episodes or whatever. In fact, in my situation, patients will come in and, I'll tell my staff, look, if they have scratches or scars on their face, that's an arrhythmic-induced syncopal episode until proven otherwise. Because usually if you trip and fall, you're going to try to brace yourself. But that person lost consciousness before they hit the ground. But either way, if they hit the ground and hit their heads, and we get these reports, fairly regularly, an older person who fall and maybe they trip and fell. But, I didn't think about the torquing of the neck, but there's mechanisms of falls. So help me out here when I'm evaluating a patient. And let's say the family member brings them in and they've had a quote unquote fall. and they went to the emergency room. The CT scan of the brain is normal, no bleed. And they come and see me and say, okay, I'm off the hook, no bleed. But from your previous comments, I don't think I'm off the hook. Help us out. What are some of the things we need to think about in evaluating that patient maybe 1 or 2 days after they've had this fall?
So you're never off the hook, but never off the hook. But I'm going to sort of to set this out based on different age groups.
Good. Okay.
Because a fall in someone who is a little bit older, and we're just going to use sort of Medicare age, 65 and above, and then when we're younger is slightly different because our brains, as we age, our brains, most of us, whether we like it or not, the brain shrink a little bit, and there's a little bit of room for swelling. There are physiologic changes. There are changes in our brains as we get older. In an older person who has, had a head injury, hit their head, they've had a fall. The first thing is, from my end always is, have you hit your head? And sometimes they don't know that they've hit their head. They say, well, I've got neck pain, and it can be the back of the head, right? They've hit the base of the skull, and they're registering as neck pain. But after that, what you're doing is evaluating, right? So, Dr. Montgomery and I get to see, what caused it? Is it a heart problem? Is it a neurologic problem? Is it a seizure that caused you to fall and have a head injury? After that, the simple things, which are, do you have a headache? Are you nauseated? Are you dizzy? Are you having difficulty with your mood in terms of irritability? Are you having trouble with your memory? All of the neurologic signs and symptoms that something has been shaken up literally about the brain. So it can be an arrhythmia and somebody goes down and they hit their head and they get up and they're fine and they're taken to the emergency room and the CT scan is normal. But a few days later, now they're starting to get a little sleepy. They're getting a little confused. They're having a little trouble walking. So at that point, we really need to have a good neurologic evaluation. It can be, you can have something called a subdural hematoma, which is a low pressure bleed. It's a small little leak that develops and develops. And as there's bleeding in the brain, pushes against the brain and can cause fairly mild symptoms, but you can be confused, disoriented, and your memory's not quite right, or your mood or your personality changes, right? So these are all the things that we need to keep track of, that we need to go and make sure that the brain gets evaluated properly. The other things in a younger individual, the things that we need to be clear about in younger people, we worry a little more about brain swelling. So in an older person, if you've had a brain injury and the brain is swelling, you've got a little bit of room for the brain to swell. But in a young person, you don't have that. And then a young person, when they hit their head, we're always concerned if they lose consciousness a little bit after the injury, that there's, the middle meningeal artery, that there's an artery that can rupture and cause rapid bleeding and rapid pressure in the brain. And then the brain is pushed downward and this leads to death. So we are worried in young people very much when they hit their heads. That's why, people will keep young people in the hospital and observe them, because the downturn can be sudden. You can get up, you're around. I mean, this is a terrible consequence of people, young people who go skiing. And when I'm talking about young people, everybody under the age of 65 is young for this purpose. Okay. But especially in younger people, they get up, they're fine. They're doing great. Then they go to bed and they never wake up. Right. So that's the reason we keep people up. Right.
Wow. Wow.
We want to make, because you can lose, you go to sleep. If that artery then decides to let loose and that bleeding occurs during that time when you're thinking somebody is asleep, you can lose them, right?
So that middle meningeal artery, you can have delayed rupture, so it can be damaged, but you may not bleed right away. So
that's right. It's a shear injury. You have something called an epidural hematoma. So outside the brain, arterial, so high pressure in terms of bleed and rapid change. So we worry about those things. I see a lot of young and adolescent patients who have sports related head injuries, right? And they may have had a head injury. They were checked out. Everything was fine. They felt fine. Whether they went back into play or not is sometimes they do, sometimes they don't. But I may not see them until 3 weeks later, when now their relationships with their friends, they're a little irritable and angry with their friends. Their attention at school has gone down. Their grades have gone down, right? They fail a test. And a student who was an A student, they just flunked the test. And now I'm being involved, right? Now it's, oh, wow. And then something happened and it was the head injury, right? So that head injury may not have seemed very severe in that moment, but that head injury led to a brain injury, which is now manifesting later. So we talked about before, not everybody with a head injury is going to have a brain injury, but many people with head injuries do have brain injuries. The symptoms may not occur immediately afterwards. They can occur in a delayed fashion. And you know what we saw with the NFL videos are very dramatic ones where you're seeing neurologic injury right away, but that may not always be the case.
This is interesting. So the mood change that may be delayed, would that prompt more imaging studies or just more clinical observation?
For me, it prompts more imaging studies. When you have a head injury and you go into the emergency room, you will have a CAT scan, right? Which is an X-ray of the brain, which is great at looking for blood and great at looking at the bones, but not very good at looking at the brain itself. One of the things we can do with an MRI, it's a different way to look at the brain. It looks at the soft tissue of the brain really well, is we can also do a special sequence. It's called susceptibility weighted imaging. It looks for iron and iron breakdown products. So if you've had a microhemorrhage, right? So what is a microhemorrhage? We've talked about subdural hematoma or hemorrhage, big hemorrhage, epidural, which is a big, fast hemorrhage. But when the brain gets injured, when there's a to and fro movement of that brain, right? The brain is suspended in fluid in our skulls, and so is the spinal cord. That injury, impact, and sometimes without impact, when there's a lot of shaking, we've heard of shaken baby syndrome. So impact doesn't have to be huge, but that to and fro injury. So the cells, in our brains, we've got the cortex, the gray cells, their axons, those brain cells send axons, which are the big cables, and then the cables are surrounded by some fat called myelin, and those are the long fibers that go into the spinal cord and all the way down to the base of our lumbar spine. That shaking, the to and fro, stretches those fibers, those axons, and we have what we call axonal shear injury. So the axons are torn and there's bleeding around that area. Whenever there's bleeding in the brain, there's going to be a little bit of swelling in the brain too. But that diffuse axonal injury, we can see those microbleeds on an MRI scan. Why is that important? It's important because it gives me an idea of how that particular brain has responded to that injury. because there are a lot of people who don't develop micro bleeds. If you do develop a microbleed and you're having neurologic symptoms, it gives me an idea that the injury for your brain was fairly significant. And we're gonna be very careful about making sure you get enough time to recover. And recovery in brain injury is also very interesting. We don't do brain rest like we used to. We know that exercise and activity, so that you've got increased blood flow to the brain to allow the brain to heal. We do gentle and a planned recovery, right? So we want always a forward movement that you're getting better, but not to do anything that could cause you to go back.
So if I'm a let's give it this young person, they've had this brain injury and they come back, they have these mood changes, and you discover this micro bleeding. So they've had, the diffuse axonal shear injury. The MRI shows a lot of this, and you put them in this brain recovery. And I'm just going to throw this hypothetical out here. And I'm a kid, and I like, French fries and burgers and pizzas and lots of soft drinks. Well, part of that protocol you provide me, and I could be a young adult or anyway, involve dietary changes, advice, in addition to other things. What's sort of the bucket of items that I need to do for my brain recovery protocol?
Well, Dr. Montgomery, you and I we speak as one on this. So in terms of brain health, not only do you have to take care of any risk factors, but in a young person, nutrition is key. So a brain axonal injury, so any kind of brain health, you must have energy and proper micronutrients for the brain to heal. And the brain is a very greedy organ, right? I know the heart rules, but in my world, the brain is greedy. In terms of our daily micronutrient requirements, the brain, the spinal cord, all our neuronal cells going, all our nerves are 3% of our body weight, but that brain is using up 35 to 40% of the daily micronutrient requirements. So one of the things that I do, especially in people who've had head injury, but most of my patients, is make sure that we actually do blood levels on these micronutrient levels, and then boost those to high normal, right? We don't, if a range for vitamin D is 30 to 100 and your vitamin D is 40, well, that's not going to be enough for your brain, especially if your brain's been injured. You really want it much higher. And we have data now, there's a growing body of information that, for good brain health, you want that vitamin D level to be 80 to 100, right? Which is really high.
Wow.
But that's what we're discovering. So nutrients, nutrition, high density, nutrient dense foods, a balanced diet, along with exercise, along with rest, good sleep, right? Sleep allows the brain to clear and renew a lot of the things it has to.
So, and this is good stuff. There's a question from the audience I'm going to get to in a minute, but so now I'm going to flip that. So we're talking about the nutrient density and of food, the nutrition, and the lifestyle aspects of recovery. If we were to flip the switch, and I don't know if there's any data on this, but I'm just going to ask this question as a quasi-hypothetical. But if we took all the players, and when we go back to the NFL, we took all the players in the NFL, and I put on one sideline the players who consume just junk food, they're out late at night, they're the fast food eaters, and et cetera, et cetera. And the other sideline, the players who, like the Tom Brady's or the Kyrie Irvings, who eat a healthy, natural, nutrient-dense diet, et cetera, together. And so we got, equal number of players on each side. Which side would you predict would have more concussions? I mean, it's kind of
right.
But just give me an honest answer. I mean, maybe there's data on it, maybe there's not, and I don't know.
There's no data on it, and I would love to get the data on it, because we've got a nice secure sort of group of people who eat similarly, maybe. But, I mean, they're in the same place. I mean, we've got the NFL. We could actually get this data. But in my world, people who are promoting good health habits tend to get injured less. Their brains tend to do better. We're talking about brain health. So anything that promotes brain health reduces the likelihood of brain injury. If you're lucky, genetics are part of it.
Sure.
I would always predict that someone who's done very, very well in terms of brain health, provided the brain with micronutrients and exercise and good blood flow, will have less likelihood of getting injured and hopefully a quicker recovery, right? That's important too.
Yeah, no, I think you're right. One last question before we close out, and thank you very much. These are excellent. I'm not sure if you use pulse electromagnetic wave function. Is basically beamer therapy is one, but someone wants to know if you would use pulse electromagnetic wave therapy in these patients. Grounding is one thing that people use, which is not pulse electromagnetic wave, but some form of regular electromagnetic wave. But there are these, electromagnetic wave mats that people talk about. We use it for microcirculation for people with peripheral vascular disease. And I was saying the Atkins have been using it longer than I've been using it, introduced to me. But have you used anything like this for microcirculation for brain injury patients or?
Not really, and there's not a lot of data on it either. The brain protects itself with that blood-brain barrier, so a lot of things that will work in the periphery may not have the same effect in the brain.
Yeah, no, that's what I figured as well. Well, this has been excellent. Dr. Fordak, Dr. Pamela, any comments or questions? I mean, I know you all see a variety of patients. I'm not sure if you see patients with head injuries or much. But I know Dr. Fordak is a football fan. I don't know about
well, what I want to say is thanks to Dr. Achari for the information, because it connected a lot of the dots for me. When I was practicing podiatry, one of my jobs at one time was being a sports medicine person for a boxing camp. And so when you talked about boxing, that hit a nerve, because what we would see with boxers when they would get hit, if they got hit on the chin, they usually got knocked out and went down. If they got hit on the side of the head or in the front of the head, they would lose that proprioception where they would stagger and fall down and get up and fall down. So you could see the difference. You could tell how a person got hit, even if you didn't see the hit, by the result. And so that was very interesting. We used to, one of the big problems in podiatry with sports like that is that the athletes would get up and they would fall down and twist their ankle or have an ankle injury after that. And so we would always tape ankles even before they fight, because they fall down. We were trying to prevent or lessen the likelihood of having those ankle injuries. But I've had several professional fighters who got knocked down and twisted their ankle and couldn't continue to fight because their ankle was so badly injured, because they're 250-pound guys or 220-pound guys, and they turn the wrong way on the ankle and they go down. So it's very interesting. When I was thinking when you were talking so much about the injury, how we could again prevent these injuries, but I guess there's no way with the helmets and all the things that the NFL say they do and boxing say they does, but it's no way to protect against a brain injury when you play that kind of sports other than quit. I guess I need to start protesting also.
Well, I don't know that we don't have the data, but we know on the recovery side, some lifestyle measures like nutrition can benefit. So although we don't have the data, maybe we should look for the data. I mean, they're looking at different helmet size. Should we look at nutrition as a way of preventing these injuries? And like you say, the NFL, we may even have the data. We just may need to analyze it. I mean, just retroactively look at linemen, some with concussion, some without, and I don't know, analyze the difference.
Well, in college football, there have been 2 or 3 studies with CoQ10 and fatty acids, where players who were on higher doses of CoQ10 and fatty acids had a lower incidence of concussion on the same team. And that has been analyzed. So there's clearly something to it. It would be great to have more evidence, again, both on the prevention and treatment side.
Wow. Wow. Again, Dr. Charlie, thank you very much. This has been very enlightening for all of us and our audience. And what I'll do is I'll close the show out and I'll see you guys backstage. Thanks again for such an enlightening, informative presentation. Well, as usual, I learned a lot on this. This is, I probably should start getting CME credits for our shows because I'm always picking up a lot of information. And I'm sure that our audience learned a lot. Head injury is something that we think is isolated to football players, but as we alluded to in the second part of the show, we are all susceptible to head injuries. It's we're all one trip or fall away. We can get our heads banged by a door or something. So head injuries are something that are more common than we really think about. Oftentimes, individuals will get hit in the head or bumped in the head and won't think much of it. Sometimes individuals who get imaging studies will not have any findings of significance. However, as Dr. Achari points out, mild changes in mood or sleep impairment, things like that, these subtle abnormalities could be significant findings of significant injury that's not picked up on routine imaging, but has to have specialized imaging with specialized MRI testing. So, I think these are great take-home messages if you or a loved one has suffered a closed head injury. And again, we're looking at concussions from an NFL standpoint. That's an extreme. It's great to look at, these things. We talk about it. But, concussion is a term that is probably a little bit misleading. It implies an extreme head injury with headaches and lots of symptoms, et cetera. But a closed head injury is a broader spectrum of things. And it can be something as simple as somebody stumbling or bumping their head on a cabinet, which may seem benign on the surface, but may lead to something very significant. So I want you to keep that in mind as we think about what we go through in our daily lives. And of course, if you have a loved one that may have suffered a closed head injury, you want to keep these points alive. So as always, give us a thumbs up. Please subscribe if you hadn't had a chance to. And of course, share this valuable information with loved ones and anyone else who you think will benefit. So until next time, keep it fresh, natural, and live.